Yes. Hi, everyone. I'm Liz Siegert. I'm the Health Beat Leader on Aging for AHCJ. This webinar is one in a series of topic-specific training opportunities to brief health journalists on the latest information in a particular health area and to give you story ideas or resources that you can use in your work. Today's topic is vaccine trends and misinformation among older adults. Flu season isn't over yet, and cases among people 60 and older are trending up. Older adults are especially vulnerable to more severe disease for a variety of reasons, but vaccine uptake in this group is still low, in part due to the rampant misinformation being put forth by U.S. government officials, some in the media, and social media influencers. Joining us today are Jennifer Dowd, Professor of Demography and Population Health and Deputy Director of the Leverhulme Center for Demographic Science at the University of Oxford, and Preeti Malani, Professor of Medicine, Division of Infectious Diseases, Michigan Medicine, and a Deputy Editor at JAMA. Both Dr. Dowd's and Dr. Malani's research look at the impacts of disease on aging. Our guests will present and then answer your questions. You can ask questions at any time by typing them in the Q&A space. Please don't use the chat. Please use the Q&A. I will direct questions to our guests. We'll go ahead and get started. Jen, would you please start us off?
All right, great. I'll share my screen. All right, how does that look for you guys?
Perfect.
Good. Okay, great. Yeah, thanks for having me. Just to give you a little background on the work I do and where I'm coming from. I mostly work with data, so not a clinician, but my background is in epidemiology and population science, and I study mortality trends and also how a broad range of factors, including infections, impact aging and life expectancy. So, and I also got pulled into science communication during COVID. So I feel like I understand a lot more where you guys are coming from about how to try to explain these things in a clear and effective way, and help people not be led astray by all the bad information out there. So I'm going to start by just giving an overview of kind of where things are with respiratory season in the U.S. right now. As Liz said, we're kind of not through it yet. It's we think spring might be coming, but we still see pretty moderate to high levels of overall respiratory illness in many parts of the country. This figure captures ED visits for respiratory illness, so you can kind of see the regional variation. And RSV in particular has kind of come up late this year. So we're seeing kind of increases right now in RSV, which usually happens a little earlier. So I think this is something to be aware of, that it's hitting later than normal. So probably will still extend into the spring a couple months. And this is the one where we have a relatively new vaccine from the last few years for older adults. And it's also really important for newborns to get protection, and grandparents who might be around newborns. So this is one where I'd say, because levels are still rising, it's never too late to get that vaccine even this season. We also have seen flu activity, be pretty high, as you guys probably know. Over the winter, we thought we were seeing that come down after the holidays, but it's not unusual what you see here in the blue line of kind of getting a double pump where there's a decline for a while, but activity is actually, picking up again. And this is, again, another case of this could go on for another couple of months. So I always say it's really not too late to get that seasonal vaccine for people who haven't. And some people have asked me about getting the vaccine if you already had the flu. In general, the flu vaccine that we use does cover 3 different strains, including I think 2A and 1B strains. And usually over the course of the season, the strains that are dominating do shift. And so I do think, even if you had flu earlier in the season, you still might want protection against the other two types that are kind of increasing in prevalence. So that's another thing I think people don't realize, that you still could get exposed to getting flu more than once in the same season. And you can see COVID, is still kind of at low levels compared to RSV and influenza, but also a little evidence of increased activity lately there. Um, and I wanted to also just show hospitalizations amongst over 65, since that's kind of the focus today. And you can see that flu has really dominated those hospitalizations for the last couple of months. And even though we see that that's come down, that little double hump that we saw in the positivity data might suggest that we'll see another increase in hospitalizations from flu. But I also kind of wanted to just put mortality from these respiratory viruses in a little bit of context, because I think, the discussion that we're having and trying to convince people that vaccination is important really comes down to whether people consider this an important risk for them or not. And so on the left, this is some data on influenza deaths in the US for the last few seasons. And on the right is COVID deaths. They're not exactly on the same scale. But I wanted to use this to kind of point out that last flu season was particularly deadly, as you can see, but this year's not so great. COVID has gotten much better over time. You can see at the beginning of that series, sometime in the beginning of 2023, we were seeing up to 4,000 deaths per week. And that's come down a lot. But the thing about COVID, as you can see, is it never, kind of completely goes away the way, flu gets down to very low levels. COVID seems to be having smaller peaks than flu right now, but is much more continuous throughout the whole year. So the mortality burden, is very similar for the last year, or even it's still a little bit higher for COVID when you add all the deaths that happen throughout the whole year. So it's kind of, not true that COVID's gone away or it's not a risk. And, of the people who die of COVID, still, it's disproportionately those over age 65. So that's the group that should be seeking this protection. And I just wanted to also get some context for the number of RSV deaths and hospitalizations. Of course, a lot of these are also in young kids, but you can kind of get a sense there that there's also, thousands of RSV deaths and hundreds of thousands of hospitalizations a year, just showing that we really have a lot of scope to, use the new vaccinations to bring these numbers down. And so that brings us to kind of how the US is doing with vaccine uptake, especially among older adults. And it's probably not surprising to you that, we've seen in the last few years a decrease in uptake of routine seasonal influenza vaccination. I guess, maybe the good news is this doesn't look so dramatic, but you can see kind of this consistent reduction year on year in the take up for older adults. So it's kind of subtle, but a real decline. And, I was comparing this, so you can see we're getting up to kind of close to 60% in our best year. But that's much lower so far this year. We were only at 40% when the last data came in for over 65s. And this is from Medicare data. So we also have National Immunization Survey data that actually suggests little higher rates, closer to 70%. But there's still plenty of room for improvement. And this is a case where the UK does a little better, covering pretty consistently 75% of the population age 65 and over with the flu vaccine each year. I thought I had COVID vaccines. Okay, I think some of my slides are out of order, but maybe we can talk more about this later from the clinical side, but I also wanted to mention that there's been kind of a resurgence of whooping cough or pertussis, which is, a very nasty sounding 100-day cough where people can crack their ribs from coughing so hard. And so I think this is just another vaccine and illness where I think we need to raise awareness because people kind of don't realize that this is resurging, probably due to, decreased coverage amongst kids. But all adults should really get a dose of this Tdap vaccine every 10 years. And if you are going to be a new grandparent or will be around newborns, it can be a good idea to maybe get one even sooner because we do know that even over that 10 years, the vaccine effectiveness wanes over time. So the RSV vaccine is quite new, as you probably know from the, I guess, maybe 3 seasons or so now. And this is one where we see that only, 36% of Medicare, at least beneficiaries 75 and over who are eligible, are vaccinated. And there was some evidence that this was, more, higher rates amongst white non-Hispanic beneficiaries. And then there's some other survey data that suggests that might be a little higher, closer to 43%. And the other category of adults that are eligible, 50 to 74 with a high risk condition, we're still seeing pretty low rates at 32%. So this is one, again, where there's a lot of room for improvement. We saw all the hospitalizations and deaths that still happen, but this vaccine has been shown to be very effective at decreasing hospitalizations in both older adults and infants, which is kind of amazing news. And this is one where the UK is doing a lot better. Also, they only offer this for over 75s, but the coverage there has reached 62% or so. And this is also one where, for now, it only requires, that you get this vaccine once or one series. You don't need to get it on an annual basis. It could be that changes in the future, but that's another reason why we should be able to get that number up of people who have had this protection at some point. COVID vaccine uptake amongst older adults is quite low, as you guys probably might have guessed. You can see here kind of around 30% in the last couple of years and kind of a noticeable lower number, even less than 20% from the latest numbers this year. And this one, really makes me sad because we know we continue to get good data each year on how even an additional annual shot reduces the risk of hospitalization for older adults. And we're still seeing lots of COVID hospitalizations and deaths year round. So, just a real opportunity to convince people of the value of this vaccine as well. And I think one thing I find interesting here is, we know there was a lot of politicalization of COVID vaccines, but the fact that our annual flu vaccine take up in this population is much higher, closer to 60%, means that, these people who are not getting the COVID vaccine are not averse to getting an annual vaccine. And I think that shows that it really is we need to kind of tell the story of why this one is as important as the flu vaccine that people are more accustomed to getting. And this is just, again, showing that the UK is a little better at COVID vaccine uptake amongst older adults, getting more to that 70% similar to the flu vaccine. So the US is kind of an outlier in that particular vaccine. I also wanted to just throw in, hopefully for more discussion, that we're starting to see some really interesting evidence of benefits of other vaccines for aging outcomes. I'm sure you saw some of the studies this year about the shingles vaccine preventing dementia. And I'll just say, I think these are really interesting studies. They're Most of the good ones that have come out have been kind of a quasi-experimental design where there was a natural experiment of the rollout of vaccines in particular countries. So they're not, based on clinical trials where the vaccine is randomized, but some sort of policy, national policy kind of randomized. And so they're considered pretty good quality studies. I think, we're really kind of excited at the prospect that this may be having an unintended benefit. But I think there's still, a lot more to learn. But there is kind of a biological basis for why the varicella zoster virus, which you get when you have childhood chickenpox, kind of stays with you your whole life and can reactivate as shingles. But we sort of think it's often kind of causing inflammation and other problems for the brain with kind of subtle reactivations, and the vaccine can really reduce some of that risk. And I think this is just one example of, we're learning that even the flu and COVID vaccines can help reduce the risk of cardiovascular events. Because if you get the flu or get COVID, you are typically at higher risk for a heart attack or stroke for, many months at least after your infection. So I think that's another area where we could really improve our communication about the broader value of these vaccines for older adults. And so hopefully we'll have a good discussion and find out, answer your questions, whatever they are. But in thinking about this broadly, it kind of just struck me that, we're in such a world that's looking for longevity hacks and special peptides and things that people can take to live longer. But it's at the same time, we have actually these amazing pharmaceuticals in the form of vaccines that we know have this benefit of keeping us alive a lot longer. And we can see from those vaccine uptake figures that we have a lot of room for improvement in the population. And so I think we just need to get the word out more effectively about how, effective these are. And it's just one of the easiest and best things that people can do for their health each winter, not just actually getting these infections, but possibly for protection against other chronic diseases as well. But of course, getting that information out and taken on board is the challenge for all of us. I was asked to just talk about some data sources that might be useful outside of government websites. I actually still pulled a lot of those kind of surveillance type figures from the government websites, but I think we're all especially looking for other sources. So these are some that I think are doing a good job trying to fill some of these gaps, especially on collating what we know about vaccine effectiveness and different guidelines and recommendations. And this evidence collective, if you click on that, also has a lot of other recommendations of specific websites that are, these medical associations are starting to kind of provide their own vaccine recommendations and evidence to support that. And these are just kind of some other sources of that surveillance data as well. So I encourage you to check that out. You probably also know there's a lot of science communicators out there trying to fill the gap as well. And that's what I try to do apart from my research. So you can check that out on Substack for my kind of regular takes on a variety of health topics. If that's of interest to you. And there are lots of other great creators who I think do a good job trying to distill kind of all of this information that's coming in. And I'll stop there, but I was also asked maybe to talk about measles. So we can come back to that if people are interested.
Yeah, I think we can come back to that. That'll be a question for both of you later in the conversation. Jen, thank you so much. That really set the table. for our next round of questions. And I did subscribe to your Substack last month when I found
Thanks.
it, and it's full of really helpful information. So I do encourage people to do that. Pretty. What are you seeing on your end of things?
Yeah, thank you. Thank you, Liz. And thank you, Jen, for really masterfully setting the table, so to speak. I'm just going to respond to a few things. Really like reiterating the fact that vaccination against common infection has dramatically improved health and quality of life worldwide. So the peptides and all those things that people maybe focus on, and those could be important, but really when you talk about just the fundamental nature of vaccination, not just in children, but in adults. But despite well-documented benefits and safety, vaccine coverage among adults tends to be poor. And I think, again, there are lots of reasons for that. But there are also some simple and inexpensive interventions that have really been effective ways to increase uptake. And I'm thinking of things like standing orders, limiting out-of-pocket costs. And in the United States, there are very few costs for older adults associated with these vaccines, fortunately. Electronic reminders, and one of the big things that I've seen in really the past decade, maybe decade and a half, is increasing and improving the availability of vaccines. And in the United States, pharmacies have been very, very central to this, as well as workplaces and schools and other places. When you think about flu shots, where do you get your flu shot? Probably not at a doctor's office for most people. And the misinformation is problematic. I know we'll talk about that. And I wanted to add my endorsement to some of the sources that Jen shared. And the Vaccine Integrity Project is one that I know a bit about, and the folks involved with that one, but the others are also very good sources. Uh, in addition to hesitancy, there's a notion of fatigue, vaccine fatigue, and I think it applies a lot to COVID-19 vaccines. And so some of that interest, that sort of disparity between these two annual vaccines, the fact that flu uptake is a little higher, some of it is confusion, some of it is not, people aren't sure what they really need, or maybe they were ill recently. And I will add that clinicians remain a trusted source of information when you poll people. And this idea of shared decision making, I think is important. And I certainly encourage people to have a conversation with whoever takes care of them. But it's a difficult time because there's sort of overload of information, and perhaps the perception that risks are too high or inappropriately high. And I shared a link from some work that my colleagues did at the University of Michigan, just asking people a few weeks ago about if they've been vaccinated, and if not, why not? And again, that idea that, well, I'm not sure if I need it, and if is it really safe? And again, not thinking that you need it is one of the big reasons. So we did talk about Jen mentioned several vaccines, so flu, COVID, the RSV, which is, again, as mentioned, it's a newer vaccine. And in addition, pneumococcal vaccine is one that gets forgotten. And that one's been interesting in that the recommendations of who gets this have changed. But it is now 50 plus, and it's a single shot for most people. And I wanted to also add to the discussion around shingles vaccine. Shingles is awful. If you have seen it or have had it, or if your friends or family have had it, and the fact that that vaccine might offer additional protective benefits is a bonus. And the reasons for why this may help be effective, or it may help prevent dementia, is not really clear. But I have to say, study after study is showing this link. And these are really interesting studies from a epidemiologic standpoint. And I know Jen is very familiar with the studies. Um, I think they're fascinating to look at them, and they've been done in Wales and in Australia, and there's a few others that are pending. And they really were able to compare groups that the only difference between them was their age by like a day or two. And one group got vaccinated and one group didn't. And then there were these differences pretty large relative risk differences in terms of who developed dementia. And is it because of the virus? And again, varicella zoster is a really interesting virus. It hangs around and stays dormant. And is that the reason, or is it that there's some kind of boosting of the immune system? And again, I'm not sure we're going to totally figure this out anytime soon. But I think to me, it's just one more reason to get that vaccine. I think it's one that people forget about, or they just don't get around to getting it as two shots. So it does take a little bit of planning. And then I know we're going to talk a bit about measles, so I'll save that. But and I don't know if I mentioned. So my background is I'm trained in infectious disease as well as geriatrics. My clinical practice at the University of Michigan is focused really only on infectious disease these days. So I tend to see the people who maybe didn't get vaccinated or were vaccinated but still ended up having breakthrough infections in the hospital. And I think one thing that was mentioned that I did want to reiterate was the benefits that go beyond preventing infection. And I think in particular, some of those are the hospitalization benefits, the cardiac health benefits, and particularly with flu vaccine. These are really large, well done epidemiologic studies, and they continue to show this benefit. And I think again, the older you are, the more likely you are to benefit from these vaccines. And so, a lot of my focus clinically is reminding people, hey, make a plan to get it. If you're a young adult, you might just be miserable for a few days. You're probably not going to be hospitalized, but it could be a big difference for someone who's older. So I will stop there. I know there'll be some questions.
Yeah, definitely. One of the things now is, people are coming in and saying, well, I heard this from this source and this from this source. We've got a health secretary that has decimated ASIP pretty much, and everybody's saying, well, you do you. What is a good way to counter that argument? Basically, if standing in line at the grocery store or why are you wearing a mask? Those kinds of things. Just from an average person's perspective that actually believes in vaccines and doesn't want to get sick. How do you counter just those basic pieces of misinformation that are coming out? Who wants to go first?
You want to take that, Jen?
You're muted.
Sorry, I was going to let you take that since you're on the ground.
Yeah, I will say I think we're in a difficult space, not just around vaccines, but around many aspects of health. And there's so much information. I guess one thing that I come back to is that clinicians remain a trusted source of information, and they do play a critical role. So this doesn't answer your question about what to tell people in the grocery line, but I do I take that seriously. I don't actually see patients in the outpatient setting anymore, just because I'm focused only on the hospital these days. But I know many of my colleagues, like, they make it part of their routine, like not just primary care, but you're coming to a subspecialty clinic. And I mentioned the standing orders. I mentioned the expectations. I think in clinics, when your entire staff is sort of on board and has good information, it's helpful also. I think that the adult piece is different than the pediatric piece, but most people still want to be vaccinated, and sometimes it's a matter of just making it convenient for them and reassuring them or reminding them which ones they need. Like, I have to say, I'm pretty up to date, but I haven't had my Pneumovax. I just, like, I'll get it next time I go to the doctor. I'm not running out to get that one, but I've had my shingles vaccine. So that maybe there are lots of people like me also where it's not that I'm hesitant or, um, I'm subject to misinformation. I just haven't gotten around to it. And I think we found that in the poll results that I shared also. But I would stress that I think if you have friends or family that have questions is get good information. Um, Talk to your doctor, talk to whoever takes care of you. And we had that discussion a lot earlier in the pandemic where, there was a lot of confusion and, perhaps directing people to trustworthy sources is helpful. But I think it is we're we're in a difficult space in terms of communicating about this. And I
Yeah.
guess just making it part of your routine conversations in clinic, the way you would talk about other health issues.
Yeah, I agree. I do think a little bit different from the discussions about childhood vaccines where a lot of those diseases are quite rare and one could argue that their child, is not at risk and it's a bit more of a public good to have that herd immunity. But yeah, in some ways, I think for older adults, we don't even need to rely on that sense of collective responsibility in that sense. Like we can make the argument that the benefits of this to you as an individual, are very large. And I tend to agree. I think people aren't necessarily rejecting it. They're just really not aware of how, helpful a lot of these vaccines can be. And so making it logistically easier would go a long way, but also just raising awareness that there's a lot of benefits to these, and it's not just all about some herd immunity or doing it for other people, even though I think that's still a good reason to get protection. Um, these are kind of direct benefits to older people that I think we just need to yeah, we need to communicate better and at every opportunity in the clinic. Um, in our public writing and hopefully in our conversations with family and friends.
Do you think, Jen, that there's a difference since in the UK, the healthcare is nationalized, so basically no cost to take care of yourself or minimal cost to take care of yourself, whereas in the US now, a lot of health plans aren't paying for, I've heard complaints, COVID vaccines now $250 or $300 if you get it. How do we reconcile that end of public health? I mean, that's obviously a whole other debate on whether we should have a national health system in the US. But can you give us a strong argument for, why this still needs to be a public health good?
Yeah, no, I mean I think about these differences a lot because yeah, there's no perfect system, but I do see um how some of these differences play out. And for vaccines, because the NHS is also very centralized, it's very clear, like people will get their notice that you're due for your flu vaccine, every year, and it is free for older people. The flu vaccine is not sort of free for, I would say under 65s. It's either, but you can get it for sort of 12 pounds at the pharmacy, similar to what we do. Um, so I think it has a benefit of both being free for older adults but also just like easy and expected. Like it's kind of built into the system that everyone gets that notice and knows where to get it. And so I think if we can mimic, yeah, if we can mimic some of that kind of streamlining of the process, and lowering the costs, and just confusion, I think, and uncertainty about the cost obviously contributes a lot to this too. Um, but I'll just say, there are challenges obviously in both systems because in that sense, the UK, because it's being paid for publicly, they kind of sometimes make different trade-offs about who's eligible for vaccines because they're looking at cost effectiveness across their health system. And so, it's not the case that just everything is universal and free. They do make certain trade-offs. But I think, when there is a recommendation, there's kind of consensus and higher uptake amongst the group that is eligible. So I think there are things we can learn from there, but it's always difficult to completely transfer things from different contexts. But yeah, make things as easy as they can be. and just lower barriers and costs to, because vaccines are just also one of the most cost effective interventions that we have. So even when you do kind of cost benefit analysis for any particular payer, I think it's hard to argue that doesn't come out well.
Preeti, Michigan and of course a lot of parts of the US, access is a big problem, especially in rural areas. How do we get these benefits to people that don't have a CVS down the street from them?
Yeah, this is, I think, well, again, if we go back to the pandemic, Liz, like what happened? How did health departments mobilize? And again, our public health infrastructure in the United States is probably not the example worldwide. And part of that is because healthcare is delivered differently here. But there is usually some pharmacy, and again, public health departments, the counties, sometimes, and again, this is why things can vary. There might be one person in the county who's a champion around this, and they may have a van that goes to certain locations. It might be a senior center. It may be a faith community, and I think those are the types of things on the ground that at a county level, people can plan for. But I think again, it is, access is very different. And even in places where you have easy access, people are busy. Yeah, if I can remember my kids are grown now, they're adults, but their school used to have a vaccine day. And I used to like make sure that I remembered that day, because if I didn't get them their flu shots there, it became a lot more complicated to get them. And if you miss that day, you might end up missing it altogether. So I don't know if that answers your question fully, but I have seen situations where there's someone who's a real champion at a county health department, and they can make a huge difference. And I just wanted to talk about cost a little bit, and
Sure.
some of that has changed. RSV for some Medicare beneficiaries and Medicare Advantage. I just know this from my own family. A few years ago, it wasn't fully covered, and now it
Right.
is. And so things can change. And shingles was like that years ago too, where you had to go to the health department to get it because it wasn't widely available at your doctor's office. And so it really took a lot of motivation, to go and get this vaccine. And I think that is not a good way at a population level to try to get benefit. And with RSV, especially in congregate settings, in nursing homes, in assisted livings, in other communities where there's a lot of older adults, like that is a place where you really want that uptake to be very high. Does the average 60-year-old need it? No, they probably don't. Um, unless they have certain health conditions that put them at higher risk. But if you're older, you're 80, let's say, and you're healthy, but you're living in a community of older adults, by all means, you really should make a priority to have that vaccine. And so I think that's where some of the prioritization also happens.
Hmm. Okay, I want to turn back to measles just for a minute. Jen, if you don't mind putting that slide back up.
Sure.
One of the questions I had, and people I was born in 1960, so I was in that early cohort of vaccine people, and I only got the one dose vaccine. So before I traveled to Europe last year, I talked to my primary, and she said, "Well, we'll test you for the titers, or you can just go get a booster because it's not going to hurt anyway." One What's up with that? Because all of a sudden I'm getting a lot of emails from peers, in this age cohort who are like, "What do I do? Should I be getting a booster? There's all these measles cases coming up." So, Jen, you want to go through this maybe?
Yeah, I think it might be a good question for the infectious disease clinician too. But um, yeah, I did want to provide this kind of helpful chart that I got from the folks at This Week in Virology, which is also a great podcast to listen to, Clinical Update. where they kind of summarize all these trends and things in a really helpful way. And this was their table from New York Presbyterian Hospital. And so it kind of, recommends what you were talking about, that there were, these people born in 1957 or later have, kind of the potential to have gotten maybe one of the vaccines that was less effective, um, and maybe didn't get the second dose that became recommended after 1989. So in that case, those might be good reasons to consider just going ahead and getting another MMR dose. And there is this, approach to testing your antibody titers, but I feel like there's a little, not consensus on whether that's a good way to assess your current immunity to measles. So, I think I remember getting one in 1989 because there was a measles outbreak in Texas when I was a teenager there. So I, feel like I'm, not in that category, but if I were unsure, I think I would be happy to go get one with the current, upswing in measles cases because, we've benefited from levels being extremely low for a long time. And I think we have to accept the fact that we might be in a world where there's just a lot more risk of anyone being exposed to measles, and that will be testing kind of these, how longstanding the immunity is that people have had if they haven't quite had the right vaccines. And so I think it's a good time to shore up that protection when we get a chance. But I'd be interested. Um,
Preeti, what do you
in what
think?
Yeah,
Preeti
so this
thinks.
is a great table. I think this is I'm just looking through it and I agree with this approach that's been laid out. And I wanted to point out a couple of things. One is sort of if you were born before 1957, you probably had measles. It's very highly contagious, and we're seeing that in outbreaks in communities with low vaccination rates. The two doses is kind of interesting. And so, Jen, much like you, when I was a graduate
Yeah.
student at Northwestern, there was an outbreak in Illinois, and it was in 1990. And so I got a second measles shot then. But because I work in healthcare, I also got my titers checked years ago. And that is probably the one setting in which people are routinely checking titers. And again, I
Yeah.
think just from a practical standpoint, would you check titers in someone or just give them a shot? If they were if they were in your clinic, you'd probably just give them a shot because they got to come back. And as I mentioned, that logistics may be difficult. I'm going to add one comment, which is well, actually two comments. One is that I think there are exceptional circumstances. If you are a kindergarten teacher in South Carolina, where, in Spartanburg, where there's an outbreak right now, and, you've had one dose, that may be a situation where you just give a second dose. If people are, um, in another high risk situation or they're traveling, those are situations. But the point I wanted to make is that it's not really adults that are the community that at a population level we're worried about. I'm also getting these kind of comments from people and emails from people, and I try to reassure them that they're one or two live virus vaccine. This is sort of the best type of immunity that you can get, and that they're probably that they're fine. They're not in a high risk community. The group that you want to really emphasize vaccination in are people that are completely unvaccinated, and that's mostly children. And so the story that I haven't seen lately that might be of interest is just what's happening in these spaces. In West Texas, the outbreak, I guess that was last fall. It's hard to keep track right now, but I think it was last fall. And I remember hearing or reading somewhere that there were lots of families coming who had not wanted to vaccinate their children, but they were vaccinating. I think you hear the opposite. You hear these situations where someone has a child that's very, very ill in the hospital, but they're like, oh, I still don't want to vaccinate my other children. And I think those stories get a lot of attention, and maybe you don't hear as much about the people who who come forward and say, I'm gonna do this, and exactly why that's happened. I'm curious. Like, was it something that someone read? Was it a conversation they had? Was it speaking with someone that they trust? Was it a clinician, someone from the faith community? I don't know what it is, but I'm curious what's happening in South Carolina. I haven't seen that story, but I also haven't sought it out. But people who are maybe looking for a story, that might be an interesting one.
Does measles have a specifically harsh effect if somebody, in their 60s or 70s is exposed to, let's say, a grandchild, who might have it? Does it affect them any differently than, mom might be?
Well, fortunately, we haven't seen a lot of people that
I
age
know.
because
Yeah.
they either had it or they're vaccinated. But
Okay.
I will say that everything is worse when you're older. It just is.
Yeah.
Your immune system is not as robust. That you have more underlying health conditions. You may have lung disease, heart disease. So it would be a bad thing to get. And I have heard of adults, like often it's a parent in the family getting measles, but maybe it's a little milder because again, they probably had at least one dose of effective vaccine.
So really
Yeah,
people,
I was
I'm sorry, go ahead, Jen.
sorry. No, I was just going to say I think that's right, but it's actually strange to think that we never had older adults who had never been exposed to measles because when everyone got it as a child and then and then pretty universal vaccination. So this it's kind of a new thing now that measles is circulating more for even I think young adults and parents age to be getting it for the first time because they were not vaccinated but had kind of avoided it. Um, and so I think it's a little, yeah, we're going to learn a lot potentially about what that looks like in adults. And one thing that I learned that people are not that aware of is measles has kind of a nasty effect beyond the acute infection of wiping out your kind of memory cells for lots of other infections that you've been exposed to. So it's been called immune amnesia. And obviously, if that happens when you're a little kid, you've been exposed to things for a few years, but you can kind of rebuild. But I'm imagining maybe adults who have that effect of kind of wiping out a good part of their immune memory. That could be a much more severe consequence of a later in life measles infection. So I hope we don't see more of that, but it's something to be aware of.
So people who are maybe immunocompromised, cancer patients, severe chronic disease, those are the people that should be especially paying attention to being exposed, possibly. I mean, I see stories now, somebody, was on a plane and later was, tested positive or something like that. So, another reason to wear a mask on a plane, I guess, too. But
Yeah, measles is super contagious,
yeah.
like way more than COVID and flu.
Yeah. I just want to turn to story coverage for a minute. What are both of you not seeing that journalists should be writing about? What would you like to see more of? And I'm also curious, Preeti, as in your role in JAMA, what kinds of things are you seeing come across? So it's really a three-part question. Take your pick.
Go ahead, Jen.
Oh no, I'm thinking. You go. So,
Yeah, in terms of stories, I think the story I'm seeing a lot of stories around the outbreaks, and the sort of what's happened with ASAP, and I don't know. I'd like to see maybe a happy story, maybe vaccines that aren't covered as much. I think pertussis is one that is really important. There's a lot of pertussis and people that are vaccinated, and so I think the piece about little babies getting pertussis and sometimes dying because they can't protect their airway. Those are I think important stories. Fortunately, with measles, the hospitalization and death rate, it's still the hospitalization rate's pretty high in someone who's unvaccinated, but the death rate is thankfully not that high. I mean, it's too high because those are preventable deaths. But when you think about pertussis, it is really something that's pretty prevalent, and it's quite dangerous for little babies. And so I think reminding people about that cocooning, everyone around the who's going to be with the baby and grandparents especially, who, no one loves grandbabies like their grandparents. And so, reminding
Yeah.
people about that. Um, at JAMA, I'm just trying to think. We've had a lot of, new vaccines sort of coming about. We've had some studies, not just in JAMA, but in the JAMA network, around sort of that next generation of vaccines. A few years ago, it was around Zika, it was around, dengue and chikungunya. Some of those vaccines are not I guess I'd say they have some more adverse effects. They're kind of limited in terms of who benefits from those vaccines. But one story that I thought was super interesting too is around malaria, HIV. The vaccines that are sort of they remain elusive. People have been working on them for years and years. There's this monoclonal antibody for malaria that was published in New England Journal. I think a phase one, a phase two, and then eventually a phase three. I'm curious on like what's happening with that in places that are endemic. Is that something that is actually even feasible from an economic standpoint? And again, I I haven't seen much on it.
Jen?
Great. Yeah, I think some of the things we touched on that I think we could hear a lot more about are these potential broader benefits of the vaccines in older people that we both talked about. So reduction in cardiovascular risk, potentially dementia. We are kind of always looking for these anti-aging breakthroughs, and I think people might not realize how far beyond just these acute infections these vaccines might be able to benefit people. So I think that's not as widely known, maybe as it could be. Um, and then, yeah, I think there's such polarization right now about vaccines, seemingly in the media that may be diffusing that a bit and highlighting that most people are very supportive of vaccines and want them and believe in them. Um, and just kind of telling that story of broader consensus and support a little more can um, maybe avoid some of the only the extreme voices bubbling up about this, kind of remind everyone that we're all on the same page in a lot of ways.
Preeti, you mentioned the monoclonal antibodies. There's a new one Moderna's hoping to get pushed through the FDA. It wasn't. I think it's on again. From the combination flu COVID vaccine. What do either of you know about this? Have you seen any data yet, or is it still TBD?
I think there has been some published data on it, and that, it was immunogenic, right? Like that's what a lot of the vaccine studies are just on. Do you respond? It's hard to actually do the vaccine of like, did you get this and then not? And those were done during the pandemic, but that was a pretty unique situation where the vaccine was highly effective and there was a lot of infection circulating. But for most things, you can't do that kind of study. And so these are immunogenicity studies, just like do you produce antibodies? But at a convenience level, the idea that you just get one shot sounds kind of neat. And in the pediatric world, there are these combination shots, but again, I think people would want to see safety and immunogenicity data. And again, I haven't followed the latest, but I heard that the FDA is going to look at the data.
For
And
now.
yeah, and that's tough, right? Because companies they plan these studies years in advance, sort of with a plan that they usually go to the FDA and say this is what we want to study, and they get input early on. I mean, that's my understanding. I don't do that type of work, but I see sort of the end product of it.
What do you know about it, Jen?
Yeah, I wouldn't say I know any more than that. But I agree that, the more we can do to incentivize vaccine research and development instead of making it really hard for that type of investment to pay off. I think that's what has concerned me about kind of all this uncertainty about the FDA review. So we really need kind of predictable, pipelines for companies to decide to invest. So for me, that would be a big worst case scenario is if companies just decided that's not worth putting their research time and money into vaccines.
Yeah, and with the older population growing, it's becoming more and more important to get those over 80 population vaccinated. It's going to become the largest cohort in a few years. So get your shots, folks. We have a couple of minutes. Do either of you have any last thoughts before we wrap up? Whoop.
Well, sorry
Oh,
about that.
it's okay.
Still don't, am I out of practice with Zoom?
Right?
Final thoughts.
Final thoughts are someone sent me something yesterday written by, I think it's Don McNeil, who is a global health writer at the New York Times, around vaccines in older adults and whether that's going to be a target. And it was in the Washington Post. It's a guest essay. I think it was sort of interesting to read, a little bit scary to read. Um,
Okay. I'll
that'll be
take a
my
look
last
at
thought.
that.
Maybe people should take a look at that one.
Okay. No, I guess I don't have anything more, but just to thank you guys for the work you're doing. I know it's hard to kind of take stock these days, and um, but we really appreciate what you do.
Well, thank you for that. And it goes back to both of you, and all your colleagues giving us reliable data to work with. Um, so I just want to thank you both for being here and for sharing your time and expertise with us. For anybody that tuned in late, you'll find the recording of this webinar at healthjournalism.org in a few hours. AHC will continue to bring you webinars on a variety of health topics as a perk of your membership. So thanks everyone for joining us today and good luck on your stories. Take care.